Actually, you will this will make it harder to not sleep, but you actually will want to turn the lights down low because we're going to look at a lot of slides. I don't know. So, technical difficulties. Yes, I just changed something. Can you still hear me?
Yeah, I can still hear you.
Okay. So we're going to talk about diagnosing caries on radiographs. And I think you guys have a little bit of, some of you have a handle on it a little bit, and you've kind of been looking at some of the, the x-rays already through interpretation. So you're probably starting to get a little bit of a feel for what it's going to be like to diagnose x-rays. The biggest thing we think about these shades of gray. And when you just think about it logically, and you know that something that's less dense shows up radiolucent or darker, what's a cavity? It's because it's lost what? The tooth has lost what? Density, it's lost enamel, it's lost minerals, it's lost substance. So since it's lost substance, it's going to be less dense, and therefore it'll show up radiolucent. Yeah. So that was the lecture in a nutshell. Go home. No, that was it. But now let's see. So I have to get hold on. Thought I was there, but I'm not quite there yet. Okay. All right. So here's the definition or the objectives. You guys can read through that on your own. So dental caries it's just the word caries is like from a Latin word meaning rottenness, and the Latin word is like carius or something. I can't remember. I don't speak Latin, but it basically comes from that term. But dental caries is the official term. We talk about decay a lot, and you might get used to saying decay or a cavity, but dental caries is the actual condition or disease. Normal mineralized tooth structure, so the enamel, the cementum, the dentin, they're all being kind of eaten away basically, or eroded away, bless you, by the bacteria. Hello? Is that what I heard? I gotta move this away so I can see. So basically when you are going to help the doctor co-diagnose, we technically, it's a weird, you'll talk about this more next year when you're seniors, but it's a weird kind of gray place where we don't diagnose certain things, but there's no way we can do our jobs effectively as a dental hygienist if we don't know how to identify cavities, caries. So between me and you, we diagnose all the time, but it's just not necessarily an official thing. But that line is starting to shift too, because there are more and more things that hygienists are allowed to do that absolutely require us to be able to diagnose whether there's decay or not. So you'll see in your career lifespan that things will kind of progress. But the examination is both carefully looking at radiographs and intraorally, so with your eyeballs in the mouth. And you really kind of need both. So a dental exam cannot be considered complete without dental images. However, you'll also use your clinical examination as well. It allows the dental professional to identify caries lesions that are not visible with just your eye. So obviously things like interproximal, if it's underneath an old restoration, things like that. Sometimes occlusal caries can be quite sneaky. It can look pretty good, and then there can be quite a lot of kind of erosion, or I was going to say degradation, but that's not necessarily a dental term, but a lot of destruction underneath the enamel, even though the enamel looks fairly intact. So there's different ways that we detect caries. We can use the mirror and light, which we call transillumination. And so you kind of get your mirror on one side and you shine the light through the other, and you kind of can help yourself look. Sometimes you don't need the mirror to do this if it's in the front. You just kind of look at how the light filters through the tooth. And when that light filters through the tooth, you can see the shadow of the decay. And then you can obviously use your mirror to see posterior. You can blow air. Anything that is decayed will be kind of a chalky, because it's lost a lot of its mineral structure that helps to keep it all nice and sealed and hard. The Explorer is another way, but you have to be very careful with the Explorer. When I was a kid, and some of you have already maybe experienced this, where the dentist gets in there and it's like, pick, pick, pick. Oh, stick, stick, stick. You have a cavity. We don't do that anymore. And if a dentist is doing that, that's probably not the best technique anymore, because they have found that you literally break apart whatever delicate crystalline structure is there that could potentially be remineralized and like healed. If you get in there with a big old Explorer and like stab at it, you're literally destroying that scaffolding of delicate minerals that are left. So they don't encourage going in there and scraping at stuff with the tip of your Explorer anymore. But sometimes you can, dentists obviously probably learn a whole different set of stuff, but for us, we want to be very, very careful with our Explorers. So visual clues: darkened, stained grooves, chalky white spots. Sometimes it's not visible, like I said. So basically we're looking at areas that we can't see so well with our eyes. So interproximal caries is found below the contacts. So we have the contacts in different areas. Contacts there's no contact here. This looks like it has a bit of a opening, but the contacts can be in different levels depending on what tooth. And then you'll get the decay right below the contact. Why do you think that is? Yeah, because the bacteria hangs out right there, right? Your toothbrush can't really reach it. So they're just not getting in there. So a lot of times in layman's terms, we'll say, oh, you got some flossing cavities, because you're talking a lot of times to kids. Kids more oftentimes will have interproximal decay than adults. Okay, so the appearance, again, looks a little shadowy. You can see how there's a kind of a shadow here on this premolar. And then on the occlusal surface of this molar, it just looks kind of stained. So, oh, this isn't the one that I mentioned it. Maybe it's the next one. I'll wait until, I don't want to jump ahead of myself. So the appearance of caries on dental images can be classified by their location. So we're going to think about the part of the tooth where the cavity is. So it's going to be the occlusal, or the chewing surface, the interproximal, side by side with another tooth, the buccal, so the front smooth surface, buccal pits. It's not going to be just on a smooth surface. It would have to have like a buccal pit. So some of your teeth have buccal pits, some of them don't. So it's not as likely, but usually it's very highly unlikely unless somebody has a habit where sugary beverages are pooling along the cervical portion of the tooth, or they have horrendous habits of like drinking sugary drinks and never brushing, and then they get this kind of cervical. But generally on like a smooth surface of a tooth, you're not as likely to get a cavity unless there's some kind of anatomical structure like a buccal pit. The same with a lingual pit. And then the root surface, the root has to be exposed. So what do you have to have before you can have root caries? What do you have to have? Recession. Guys are so smart. Rampant and recurrent caries can also be viewed on radiographs. Rampant is like, it's everywhere. It's just like an excessive amount of caries throughout the mouth. Recurrent means that they fixed it and then it's come back. So usually it's underneath an old restoration. So caries is divided into classifications of decay or how advanced or deep the decay has gotten into the tooth structure. So this is just forewarning. I learned this last year when I was teaching it to last year's class, that these classifications can overlap with other classifications. So just understand when we're talking about classifications for this class, we're talking about different than the class 1, class 2, like location of the restoration. Or have you guys even, I see shaking heads. So they're different classifications. There might be some similarities that you might find, especially with the class 5, but this is talking about how advanced the decay is. And I don't know that it lines up perfectly with what you guys have. Okay.
The other one's just like the area, the location.
Okay. Okay. Good. Cool. That's stuff you're getting from Kathy, Professor Moore's class. Okay. Good. So an incipient interproximal caries is a class 1. We have decay that has just gotten into the enamel and it has not passed the halfway mark. So class 1 in the enamel, not past the halfway mark of into the enamel. Extends less than halfway through the thickness of the enamel. Moderate interproximal caries or class 2 extends more than halfway, but does not involve the DEJ. So class 1 and class 2 are enamel only, either less than halfway or more than halfway. So here's an example of a class 1 on this premolar here on 29. You can see it's just like a little notch on the side of the tooth. So we call that an incipient lesion. Little notch. Could possibly be remineralized with flossing and fluoride. Incipient, yeah, we call it incipient lesion. Less than a half. Less than a half. Interproximal caries class 3 means that it's advanced past the DEJ. So it's gone into the dentin, but less than a half. So just like half, the first one, less than a half into the enamel, class 3 is less than half of the way into the dentin. Between the DEJ and the pulp is now the next kind of set. And then severe interproximal caries is class 4, and it extends through the enamel, through the dentin, more than halfway, but it doesn't involve the pulp. And these can be a little bit, depending on how good a quality your x-ray is, these can be a little bit tricky, especially the samples that we have for you guys to look. Sometimes it's like, I think I see it, that's more than halfway to the pulp. No, I don't think it's more than half. Sometimes it's hard for us to tell, but we just kind of keeping those parameters in mind. No, I don't believe it involves the pulp. It's half the distance toward the pulp, but not into the pulpal chamber. Yeah.
Class 2 is more
than yeah. And then 3 and 4 is less than half into the dentin and more than half into the dentin. So class 1 and 2, just enamel. Class 3 and 4, enamel and then into the dentin, half or more than half. Okay, so interproximal lesions, they're larger in real life than they appear on the x-ray. So if you see that it has broken into the dentin and it doesn't look that bad, it could actually be farther. So that's why when it's getting close to the pulp, the dentist is like, ooh, because you could easily get close enough to a pulp horn where you start to see pink. Or even if you don't get that close, if it's that close to the pulp chamber and they put a restoration, the thermo changes can irritate the pulp enough. Yeah. If you, with your eyeballs, like if you look into the decay, usually there's enough. It's probably rare that you would see pink unless it's, because what happens with decay too is as the decay grows, if the person is ignoring it, they build up sort of like a little bit of a protective, it's like it kind of shrinks the pulp chamber because your body's trying to seal it off and protect itself, but that doesn't always happen. But typically with your eyes, you don't see pink. You usually see like Caries dentin and enamel, which just looks kind of black and brown and soft and stuff like that. So you usually don't see pink with your eyes, but when the doctor's prepping it and cleaning it out, they can for sure. So if you're assisting, you could for sure see it. Okay, the lesion is larger than it appears on the radiograph. Cannot determine the real, whether it's a real cavity or just demineralized from a radiograph. So some areas in the mouth will, if it's incipient, they might have a lot of demineralization, meaning we kind of call it like, it's almost like pre-cavity sort of. If you don't reverse this demineralization, it's going to advance and you're going to get cavities. So that period is a time when they could kind of remineralize and heal some of those areas. You can't really distinguish that on an x-ray. Small lesions, class 1 and 2, don't necessarily need to be restored. They could potentially remineralize with fluoride or just good oral hygiene. And then demineralized caries are called arrested. So sometimes you get a cavity that was a small one, like in class 1 or 2, they remineralized the area and then it leaves kind of a scar, because if that area is demineralized and it's taken up stain and then it's remineralized, that stain stays. So it might have a weird look to it, but if it's nice and hard and it doesn't get real chalky when you dry it off with air, then it's just remineralized with that stain in it. When it's demineralized, it stains it's like a chalky white. But when it's at that stage, if you say they drink Coke or they drink something dark, tea, coffee, while it's demineralized, it might take up the stain. And then if they get better with their oral hygiene and they remineralize it, it's like it seals in the stain, sort of. So the tooth might sort of, we could call it healing, but it might heal over or remineralize with stain. And that doesn't go away. That doesn't change. Okay, so an example between 8 and 9. What classification do you guys think that this is here? Oh, yes. What's that? You guys, what it says, like, is there calculus? And then this little blue circle goes up. Can you guys see this little notch right here? It's a little bit of calculus right here. Say it again. Yeah, so now we'll circle the cavity. That I should have reversed the order. So here's the cavity between 8 and 9. And then what classification do you guys think this is? I hear a couple 2s, couple 3s. It is a class 3 because see how it's pretty broken solidly through the enamel? And then you can see the shadow here, the shadow all the way along here on both sides into the dentin. It's hard to, it is hard. Yeah. Yeah, it is hard to see, I know. And and when you're closer up, it's even harder. But the basic outline of the decay is right through here. It comes in and it cuts in into the side of the enamel. This one is cuts in and it's like right through here. It's hard to. When I was in school, we like looked at the light boxes, you know, and looked at real radiographs, and you guys will do that in class, but in lab. But it's hard on the projector. Yeah.
Would you be able to just go over like what the blue is circling, what the red is circling?
Yes, yeah. So the blue is circling a piece of calculus. So this here, now the red is in the way, but there's a little spur right here, and we'll see more of that when we go over perio. There's a little spur right here, and that's buildup of calculus deposit. And then the red is circling decay between 8 and 9. So this is decay class 3 because it gets into the dentin, and this is on number 9. This is class 3 as well because it goes into the dentin. Okay, another example. So the example here, so now we're looking at 12 distal. We're looking up here, 12 distal. What classification of caries can you see on 13? This one. I was gonna say, I don't see decay on this tooth. By the way, what is this you've got? What kind of filling material is this? Brilliant. Okay, so now we're looking at this tooth here. So this is 12. So what classification is 12? It is severe, yes. Yeah. And so if you, how else would you say severe? What class would you call it? 4. So can you guys see how the decay comes all the way into this area here? So it's into the enamel here. See how it would look pretty small because it's only an opening of here, but then see how it balloons out underneath. Dentin, you guys probably remember this, dentin is softer than enamel. So it burrows a little hole in the enamel, and then it kind of like goes out in a, you know, a bigger. So where do you see any calculus? Yeah, you see a good spur on 14. Anywhere else? There could be, it's hard because it's so kind of overlapped. What about down here on 19? Little spur on 19 there. Yeah, right here. Although, even though this looks very small on 19, and I don't know how well you guys can see it on the projector, in real life, that would be a click. You'd be like, oh, oh, I can feel that. Yeah, Tala. Yeah, so I wish I could draw. I wish I had a thing where I could draw. That'd be so much nicer. But the decay through the enamel, it breaks in right here. That's where it breaks into the enamel. And then it comes all the way in, all this shaded area, all through here. This is a big, big cavity all through here. It's getting close because it's a class 4, so it's more than halfway through the dentin. So it's getting close to the pulp. So that's why it's a class 4. So that's a severe, very large decay. I don't know if a dentist would, you know, I think they do fill class 4s, but I think it just would depend on the dentist and what they, you know, and then they have so much experience knowing by looking at an x-ray, like, oh no, that location would get us too close to the pulp. Or they might say, oh yeah, that's totally something that they would have to, that's their expertise, area of expertise. But the dental therapists, actually, they learn stuff, so they probably could answer that too. Yeah.
So if it were
Yes, yes. So if it gets close enough to just chronically irritate the pulp and it gets into this chronic pulpitis, they might have to go back for a root canal, or sometimes it gets irritated for a little while and then it calms down and then it's fine. Or if they literally punch through and get into the pulp, they'd have to do a root canal. Yeah. There is a 5, but it's a different area. So I think the next slide should be coming to that soon. Hold on just a second. Okay. So then we're talking, so all of that is pretty much like the class 1, 2, 3, and 4. For this, for our understanding, is all interproximal. And then root caries for us is a class 5, which I think is sort of similar to the other one, but not, maybe not quite. So I don't even want to like, we'll just have to separate them in your minds just in case you get, I don't want you to get overlapped and get the wrong. So for us, so root caries is a class 5, and that's going to be anywhere below the CEJ. It's also called cemental caries because obviously what's covering the root is cementum. So they could call it some, I've never really heard anybody like call this in private practice. They always just call it root caries that I've experienced. But other terms are cemental, radicular, and senile. And I think it's because the older people tend to get, and so maybe those are terms from other, you know, like maybe that have been used in other countries. I've never heard those in private practice. We've always just called them root caries, but the book says it, so we share. Yeah. I do feel like they're on exam 3. I feel like there's a question that asks for another name for root caries. Sometimes those kind of things, I feel like you don't really need to know that, but then the board might like a question. You know what I mean? I don't know. Maybe the national board likes to say, what's another name for root caries? And then you need to know it's radicular. So I don't know. I feel like it's probably not a bad idea to leave it there. But just to let you know, I've never in 20 years heard anyone call it anything other than root caries. What's that? I don't know what. Yeah, GV black is definitely, might seem similar, but it's different. So just think this is for radiology. This is for identifying it on radiographs. So just call it like your radiographic classification. It's not really labeled as anything specific in the book. Matter of fact, I don't even know if that's, you can Google it and they will have this same kind of thing. But I just want to make sure you guys know that they're different. So I don't want you to get confused and mix up the two terms. Okay, class 5 example on 20 distal. So here we have an example of root caries. You can see where the CEJ is here, and there's bone loss, so there's recession. So that's going to give that potential for caries on the root surface. For radiograph interpretation, you'd have to have recession. You'd have to have bone loss for a class 5. And that's going to come into play for when you're looking at something and just trying to determine if it's root caries or if it's cervical burnout, which we'll talk about in a few minutes. But this is the other reason why clinical examination is great, because you can diagnose root caries with your eyes too. You know, you don't just have to rely on x-rays. So you'll be looking at their mouth and you can see if if there's decay on a root surface. There's the decay on the root surface there. So then a buccal or a facial / lingual caries, these can be difficult to pick up on a radiograph. They're not going to be as obvious because they kind of come in, they generally look like a little circle or an oval area. You might see it under another restoration. So this one is very, very light. You can see it's a little circle right here. So this is like probably a buccal pit on this molar. And then over here on this x-ray, it's kind of off to the side a little bit. And you could get confused looking at them in radiographs. You might get confused because they can look similar to an occlusal. But then again, this is why you have your clinical exam part. You can occlusal decay, buccal, lingual decay, root decay, all of that you can verify with your eyes. So it's not like you just are going to be using radiographs. Yeah, so the decay on this one is back here. And then the decay on this one is where that little arrow is. That one helps, and it's a little circle, just a little circle. And also that can be kind of tricky because, you know, right in the center of the tooth is the radiolucent, pulp. So that can be kind of confusing too, because it's in the same area. Okay, so then occlusal caries. For occlusal caries, incipient is not pictured, but that would just be some decalcification right in the pits and fissures, and it wouldn't have broken into the dentin at all. The moderate would extend down into the dentin. And it's just going to make this whole underside on an x-ray, it's just going to make this area where the enamel and the dentin meet, it's just going to make it more radiolucent. And typically you wouldn't have any radiolucency there. You would just see the pretty stark difference between the enamel and the dentin, and you wouldn't get this kind of radiolucent line. And then as it extends, it'll just fan out, and it follows those dentinal tubules, and so it kind of fans out. And it just becomes larger. And clinically, there'll be a hole at this point. Those pits and fissures will have widened and opened up, and you'll have a cavitation or a hole. So for an incipient occlusal lesion, one thing that you'll learn, I think either over the summer or next year, who here who's an assistant has seen a diagnodent? Has anyone seen a diagnodent? It's a diode laser that you run along the occlusal surface, and it like gives you a number, and that number correlates to how mineralized the tooth is. So if the tooth is demineralized, or if there's a cavity brewing, it gives you a number that kind of alerts you to that. And so some doctors love their diagnodents, and they have you use it on all kids. Because you might not see visually a decay, but if you run the diagnodent on it, it gives you a number, and it's like, oh, that we got to, do something here. So that's another way to clinically check for occlusal caries. It has to be a virgin tooth. It can't have a restoration on it. I've used it not that often. Like I worked for one dentist that loved it. He wanted me to put it on everybody, but then I worked for like 5 others that didn't. So that I'm not entirely, but you guys will find that. You'll go out and you'll find a dentist that has this one thing that they love to use, and they want you to use it. So we have to kind of let you guys try it out, but we even don't use it that often in our own clinic. You'll use it over summer just so you have experience with it. Yeah. It just depends on the person. Like it could look pretty stained, but then some people just have stained occlusal. Maybe they demineralized at one time, they got some stain, and then, so it's kind of hard to tell. But generally speaking, it would be staining that starts to widen, like open up. The pits and fissures will open up with the more decay that is developing. Okay, so here's a kind of a blurry image for you guys to look at. Okay, so can you pick out some decay here in this picture? So you're looking here? Oh yes, this one, yep. Yep, so 19, this has a pretty big, or no, this is 32. Oh, 19. So this has a pretty big occlusal, and then you see the interproximals on either side. Well, this would be, I think it's backwards on, because this is, well, if we're looking at it this way, and then we put it on our mouth, so it's 19, yeah. And then here we have our incipient. Over here, do you see that little notch here? This would be a class 1. Actually, this one might be farther than that. This is hard to tell, but I think this one could be going into a class 2. It's hard to see where the shadow ends. But this one, you can see how it's kind of makes a sharper angle here. And then do you see the darkness here? So at first glance, you might say, oh, this is just in the enamel. But if you look at it a little bit longer, you can see that it's shadowy here. And then what about up here? There's a big one there. This one here, this one. Yeah, so this one would be then 14 and it's a class 4. This one, so here's the pulp chamber. Here's the pulp chamber here, and then you can see how close this shadow is to the pulp chamber. That's a class 4. So 20 is just in the enamel, but I think we could call that a class 2. And then 19 mesial is a class 3. And then this is certainly a class 4, because see how close it is to the pulp, the horn of the pulp horn. They go up, and so it's going to be, you have to think about where the decay is. If the decay is an area where the dentin is close, you know, there's not as much dentin between the outside and the pulp, then it's going to take less time for that decay to get to the pulp. What's that? So depending on like where the decay is on the tooth, like if it's closer to if it gets down closer to the sides, there's less dentin. So it's going to take it a quicker time to travel to the pulp. So you know how we say like halfway, more than halfway, less than halfway? It's altogether a shorter distance. So that's why root caries can cause a problem so quickly, is because there's not a lot of structure there. Where up on top, you have so much more tooth structure. Okay, 19, 21, and 14. So let's see. No, go back. So on 14 up here, some of these I made circles, some of them I didn't. So on 14, we have a little decay here. And it's more, I can see with my eyes, at least it comes to here, which would be more than halfway. We got a class 2 on 14. And if we drop down to 19, can you guys see all this shadowy stuff under here? So this is pretty big, occlusal decay. Oh. I try to make it the best picture I can find that doesn't, but even last year I remember people were like, well, I think it goes to here, or I think it goes here. So I had to debate with several students last year, and so I try and make that not have to happen, like find the best picture I can find where I know that I'm 100% confident looking at it, and so then I can confidently say, no, this is, so that there's no kind of arguing ability. But it's hard, you know, but I just do my best, because you do, yeah, get your probe out and measure it. So it is hard. And some of these pictures, you know, are better than others. So I try and for the exam, and I do have a Kahoot on this. I have a Kahoot on Caries and perio. So I can, but the Kahoot, you either will do it, and maybe we'll start out next, no, we have the exam. I was gonna say, maybe we'll start out the class with the Kahoot, but that won't work because we have the exam. Anyways. Yeah, we could, but I don't think you can really do it until you kind of know the material a little bit better. Okay, moving on. Okay, and so we have the occlusal here, and then on 20, there is some decay coming in here on the occlusal, and then coming in under here into the dentin. So we have a class 3 because it's in the dentin. Yeah.
Do you have any on the left side or the mesial side?
Over here, down in here. So good eye, but what you're picking up is cervical burnout. but that's a good eye. But what's happening here, and the reason, and we'll talk about that in just a second, but the reason why you know that that's cervical burnout and not decay is because the bone level is normal. So if the bone level is normal, you really wouldn't see, and we'll talk to you about why it's cervical burnout in a minute. So just jumping ahead, but that's a good eye to observe the change of color on the tooth. Okay, so here we have a couple more. So 13 over here, this is a better one for actually seeing the decay. You guys can see the break in the enamel pretty clearly there. This goes into the dentin. So what class would that be? 3, yep, class 3, because it goes into the dentin. This one over here, we see the break in the enamel really clearly into the dentin. What do we have there? Good, class, yep, class 3. Did someone ask a question? Is it halfway through the dentin? I don't think so, because see, where's my pointer? I think it ends about here, and you still have a fairly good amount. So I would guess no, that's my best guess. And I would think halfway would be more like here-ish. And then 18, on 18, this is a good example of what? Yeah, occlusal, good. And this one is a class 4 or more than halfway through the dentin, because it's getting pretty close to that pulpal chamber. Oh, would we still use class 1, class 2? If you remember it, like less than half in the dentin, more than, or less than half in the enamel, more than half in the enamel, less than half. If you remember that and you compare it to your class 1, class 2, and you say occlusal class, whatever it is, 2, 3, or 4, I wouldn't count it wrong. And then because I think I've labeled them myself that way, I don't think they have that originally in the PowerPoint. They just say it goes with interproximal, but I think you can apply it to occlusal as well. So if you said mild, moderate, or severe, or class 1, class 2, that either way would be fine with me. But it might just be easier to use that classification because you're looking at the dentin and how far it's traveled. Okay, so here we have some more. So we have on 13, we have on the mesial, there's a class 1, so it's just barely, this is incipient, probably would be able to remineralize that. On the distal, we have a class 1, but I almost would argue that looks closer to a class 2, frankly. Yeah, good. Well, I'm glad we're in agreement there, because I'm like, I don't know about that. And then 14 mesial, again, it says class 1, but I feel like it's getting kind of close to the CJ. I mean the DJ. And then distal, definitely into the enamel. And then this one ends about here. So what would you guys say for that one? It's on the border, isn't it? So that's a tricky one. I think I had that one on an exam, and half of them said 4, half of them said 3. So I probably wouldn't, even though that's a pretty clear class 3/4 picture, that's a hard one because I feel like it's really close on the border. So I don't know that I'd use that on an exam again, because you could argue that you see it all the way out here, which is halfway, because especially when you see this kind of shadow of the pulp horn, you know, so that's a kind of a tricky one. So I think that's like a 3/4. That's right on the border. Okay, and then 20 on the mesial, we have recurrent. Can you guys pick that out? So we have 18, 19's missing, 20, and yeah, this little notch, you see this little notch right here? That's the recurrent decay on the mesial of 20. And then you see how this looks a little bit rounder and darker right here? So that's a little bit of a facial decay. And it's tricky because it's right in the pulp chamber, but it just has kind of a different look. It just looks more radiolucent. Yeah. It could be. Yeah, it totally could be because it looks kind of weird up there. Yeah, good eye. It does. I don't know because I'm not a dentist, but I totally see what you're saying. And it could easily have traveled all the way up here. So yeah, that's good. Well, this is weird because typically you wouldn't necessarily have anything on there that would necessarily, so I don't know if that's coming from, I don't know what would be triggering that initially, because I can't think of like a pit that would be there, unless they had, some decalcified structure that maybe when they were younger was, kind of pitted, and then it just gave an entry for decay. I've seen patients have like perfect little holes on their like buccal surfaces in areas where they wouldn't normally have like a buccal pit. It wasn't like a normal area for that, but they just had like a little hole, and it's like their enamel just did something funky. So people can have different things like that and be kind of weak spots for decay. This is so this one is a buccal or a facial. This one's considered a facial, and then this is the recurrent decay over here. Sorry, this is the facial, and then this is the recurrent. So that's not considered an occlusal. Okay, so now what about over here? So now what are we looking at? Cervical or root caries, right? Root caries. And that's a root caries because the bone level's down here. So this can be, if the bone level was up here where it should be, well, it still would look weird. That cervical burnout usually looks more diffuse, but we can tell that that's probably root caries because the bone level's low and it has a fairly kind of demarcated border. Also looks like there's some, what do you guys see down here? So see how big this decay is and how close it is to the pulp chamber? And then you see this radiolucent area down here, that's periapical abscess. It wouldn't be decay, it would be bone loss from inflammation. So there's an infection and it ate away. So this, you mean like down here? So the infection, it tries to find a way out. And so it starts to eat the bone away around the apex of the root. And so that's why you get this radiolucent area around the bone. So the tooth structure itself is intact, but the bone around it is gotten eaten away. And then once they fix it, the bone hopefully regenerates. Yeah. It could if it got that bad. Usually though, a lot of times when it's like this, patients may have some pain, but not always. If it finds, there's something called a fistula, and it's a tract that it's where the infection bores its way all the way out to the outside of the patient's jaw, or it could be up on the maxilla, and it looks like a little pimple, but it's a pressure valve where the infection, it's like a pimple, and the infection is able to come out, and so the pressure is released. So if they have something like that, their pain is not so bad. But typically, if they need a root canal, they'll have enough pain that it would send them to the dentist and they'd get it fixed. But yeah, they certainly could have mobility if enough destruction happened around it. Yeah. Yes, they'd have a root canal and probably like a crown or something, or they'd fill the side here, they'd fill the decay there, and have a root canal. So here's the cervical burnout. So cervical burnout happens on a tooth that has normal bone level. So that's the key to remember, is it happens in healthy periodontium, healthy bone level. And the reason you get it is if you do a cross section of the tooth, so you wallop off the crown and then you look down at the root like that, it has those, you remember from your root morphology, your tooth anatomy, if you guys have hit this part yet, you have like the root depressions. So those root depressions, so if you're taking an x-ray from front to back and you have the root depressions like this, and then you're taking your picture, that middle area is less dense, right? Because of just the shape of the root. So when you take that picture from, you know, buccal to lingual, and you go through that way, you're picking up less tooth structure. So it looks like this radiolucent kind of area coming across. So you can see it coming across here, coming across here, coming across there. It doesn't do it always. It just kind of sometimes depends on the angle. But again, it's always in a healthy periodontium. It's not going to be on somebody that has bone loss. So you can look and you can see where the bone level is. And you could say, well, not only can I verify it with my eyes, I can look at their teeth clinically, but I can see that their bone level is high and there's no way a cavity forms below the bone level. That just doesn't happen. So. Okay, radiographic interpretation. So cervical caries versus cervical burnout. So we have the bone level is up here and up here. And then you can see the other thing too is burnout is more gradual. So here we have an example of caries where it looks very notched and very kind of distinct. Whereas cervical burnout is a little bit more just diffuse, sort of. It's like a diffuse shadow right around the CEJ. And so here's kind of a side-by-side. Caries is usually a little bit more like darker and more demarcated sort of, and cervical burnout is a little bit more gradual and diffuse. Caries does not usually occur with normal bone height is the disclaimer there. Caries has a more defined edge. Cervical burnout is a little more gradual. So here's a couple things that when you're looking at radiographically, you can always verify clinically as well. Cervical abrasion, a lot of times we call this toothbrush abrasion, but we also talk about abfractions, which is something you'll learn at some point if you haven't heard that word already. But when people clench and grind a lot, the pressure of them biting down and grinding can actually wear away at their cervical margin of their teeth, but then they can also brush away areas if they brush really hard. So it ends up looking like these clinically, you're looking at these notched areas right along the cervical portion of the tooth. And on a radiograph, do you see how you have this radiolucent ring around the tooth here and here and here? It's like it kind of looks like a ring sort of. So that is what you're seeing radiographically is just, again, it's less dense because they've worn away structure. So it's a notching at the cervical, more well-defined than caries or cervical burnout, usually due to toothbrush abrasion or oral habits like clenching and grinding. Recurrent decay is going to happen underneath an existing filling. So here's just kind of like a picture of it where it'll happen like right underneath the margin. Here it is on this, underneath this amalgam. So there's micro leakage, and depending on the patient's habits and how well the tooth was put in there and just a number of factors, that micro leakage can let in bacteria and it just can get more and more bigger and bigger decay. Maybe blocked by a shadow of the restoration, so you don't always see it. Many times dentists will remove old fillings and they'll find decay and they didn't necessarily see it in the x-ray because the fillings, large fillings, can block a lot of stuff. Like a bat. It's funny, you can see weird, people always told me that their x-rays look like toes. I got that from so many patients. My x-rays look like toes. I'm like, how does everyone think x-rays look like toes? I don't know why. Recurrent decay. So you can have recurrent decay under, you know, all sorts of margins, but this is obvious. Let's talk about a wing. Here's a massive wing of an overhang. And so something like this is going to trap a lot of bacteria. And so you can get a lot of recurrent decay. Yeah. They should. Totally should. And you can actually, and I think Gail maybe talks about it. I can't remember who, but you can actually go in with your instruments and you can actually try and smooth off. Now that would probably be pretty hard to smooth off, and you might end up breaking something. You know, I've gone in and smoothed off smaller overhangs, and you just go over it and over it. It dulls your instrument like anything, but you just go over it and over it and at least try to improve it. But if it's really bad, the dentist needs to address it. I mean, because that's a major problem long-term for perio health and caries. Okay, so example of bite wing with restoration overhang, and then any other caries. Do you guys see any caries anywhere? I actually think that I kind of have a feeling that's actually abrasion. Because look at how like uniform it is. It's very dark and it's very uniform. So I sort of have a feeling that it's from either cleansing and grinding or brushing. It could be decay, but I think it looks more like the abrasion to me. Yeah, I think this whole dark area is probably abrasion. Yeah. And then it's hard to tell. A lot of this I think is cervical burnout, just because it looks a little bit more diffuse. Back here is a little tricky to tell. This looks like cervical burnout to me. But some of these look a little bit more almost like decay. But this one here, I think, is abrasion for sure, because it's very dark. It's very dark and it's uniform straight across. I think this is probably cervical burnout too, but it's kind of, actually, I don't know, that's a good one. That's kind of like, it does kind of look like decay. But this patient could have, because if you look at all the way across, there's a little bit of a radiolucency all the way across. So they could have just generalized heavy brushing. This would be a good one to see their actual mouth. Yeah. The top ones. Maybe some recurrent decay under here, perhaps. This is like maybe like a class 5 like a buccal restoration. This is 3. Yeah, so 2, 3. The distal over here. Oh, this right here. It could be, that could be root caries. It gets awfully dark. The quality of this is also not great. But it does look more notched, so this could be root caries. That for sure is interproximal caries for sure, but that's just in the enamel, right in between here. Yeah, but that's definitely, and that, I guess I'd probably say that on 31, it's class 1. And I'd probably say class 1, although it's getting awfully close to class 2 on distal of 30. Yeah, that's interesting, but I have a feeling, to me, that looks more like a abrasion. Okay, we're getting there, and then we'll take a break. So enamel hypoplasia, so the enamel's gonna look mottled. It's not gonna be nice and smooth in the mouth. It's gonna be kind of mottled or moth-eaten almost. And on an X-ray, you're just gonna see, like, instead of nice borders, you're gonna see kind of like this ripply, irregular look on the X-ray. So you see areas of radiolucency here and there, and it just kind of is this kind of funny pattern. And if you just looked at it, you might say, oh, that's decay. I mean, if we didn't have any reference, we might say, oh, that's decay. But if you have the patient in front of you, you can see that they have this kind of mottled enamel hypoplasia. It didn't form correctly. And so that it transfers to the radiograph. So this isn't the case where many times you have to have a patient, you have to have the patient there to give a definitive diagnosis. Okay, how about here? Any caries in these pictures at all? What do you think about this kind of generalized darker as you kind of come all the way along here and then like all the way here to this area here? Abrasion. Yeah, yep, this looks like abrasion to me. Okay, what about here? Can you see calculus here? Calculus up here. Underneath this overhang, there's some calculus. You can see a little here. There's some in between there. There's something underneath here. They got it everywhere. It looks like they have some, yeah, under this crown. Yep, so they got all kinds of stuff happening in their mouth. Lots of that overhangs, lots of calculus. What about this? Where's the caries here? Yeah, that's a terrible X-ray. You can't, it's non-diagnostic. So that shows you just how important it is, obviously, to get open your contacts so you can see. Okay, beginner's guide, what is this? Let's see. So this is kind of showing some of that enamel. So see how it just has kind of this funny sort of pitted look along here. So, and then you can see it in their mouth. You can see these areas where the enamel is like right through here. It just isn't smooth. It kind of has this pitted. So it'll translate to the X-ray. I'm repeating what that other. What about caries here? Any caries? Are you looking in interproximal? Where are you looking at? Oh, up in here? Oh, up here? I think that possibly could be the pulp, although there is something going on there, it looks like. Just mostly wanted to point out this here and over here, which almost looks a little bit worn to me, but it could also, this also is some cervical burnout here. But yeah, I do see what you're saying. It kind of looks like there's something going on up there too. Okay, and then you guys, can you see the calculus on this picture? Up in here, you're gonna love seeing calculus on x-rays. You'd be like, ooh, ooh, because if you see calculus on an x-ray, even if it's tiny, it's big in the mouth. It's bigger in the mouth. So that's kind of, when you see it on the films before you've even started exploring, you know, you're gonna have to say light, moderate, heavy. If you take your pictures and you look at your patient and you see calculus, moderate, just start putting in some moderate, because it's not going to be light, it's going to be moderate if you can see them. Okay, let's take a break. So it's 2:06, so let's come back in just like 5 minutes because we still have a lot to go over and not a lot of time. Activity, and I can't get it to I can't get my sharing screen on Zoom to look at the dot cam, and I'm sure there's a way, and I just don't know how to do it. So you guys can see it here, but I can't record it in a way that you can hear me talking, but you can't see the picture. So I came up with 2 little activities for the classification and for staging for the perio as well. I have another one here for perio. So you might just want to do this at home when you have like access to different colors or something. But the goal of this was for you guys to label these in different ways. So some of them are kind of obvious, like this would be an occlusal decay. It's not necessarily supposed to be a classification. It's just to remind you of where you would see occlusal. And you could change, like you could make a key down here saying, you know, make a little box and color it and then say red equals occlusal. And then you could color this in, and then you could even extend it into the dentin if you wanted to. So you can manipulate this and kind of have it be a sheet that helps you memorize different stuff. But this is just supposed to be occlusal. And then here we have the class 3 and 4. So this first little notch goes with this line, and this is the decay has come into the, all the way through the enamel, and now the decay is into the dentin less than halfway. So you might write class 3 less than halfway into the dentin or something like that. And then we have this one here that's pointing to the bigger decay, which is into the dentin more than halfway. So this would be class 4. So it's, and if you have access, you know, if you can do it when you have more like colors or something, you can, maybe that might help you. Some people like to learn with different color, their color code stuff. Cervical or root caries down here, this would be like a buccal or a lingual pit or a buccal or lingual caries. And then over here, this tiny notch is going to be a class 1. So that's for this line up here. And then the slightly more than halfway into the enamel is a class 2. So it's just something for you guys to kind of work that out when you're going over it more. So that's that. And then I have another one for the periodontium, but we'll look at that in a second. Did anyone have a question on that? Okay, so now when your brain's about ready to pop with all the info, we're gonna tackle perio. So this is, you guys are gonna have actually quite a bit of time before you're tested on this. Next week in lab, we're gonna do caries identification. The week after, we're gonna do perio identification. So there's actually quite a bit of time for this to kind of soak in. So if we just kind of do an overview of it, and I kind of, you know, bust through it for time's sake, it's not like your exam is like next week. We have some lab time to talk about it and stuff like that. And there'll be this recording, and then there's recordings that I did last year. So there's a fair amount of time and resources to kind of let this. But remember, this is surface perio. You guys have a whole perio class. So this is like just getting you started, basically. Okay, so the limitations of x-rays for diagnosing perio is that you're looking at something three-dimensional. This is the limitation no matter what, but you're looking at a three-dimensional structure and taking a 2D picture. So everything's overlaid, and we've already kind of discussed that limitation in relation to other things as well. It doesn't show the exact morphology of the root. So those dips and curves and stuff, you don't see the exact precise morphology. And it doesn't show disease activity. It's a moment in time. So you don't see active disease. You see one picture of what's happening at that moment. Never substitute a full clinical periodontal assessment for radiographs. You can look at your radiographs and go, oh, wonderful. I can give a good estimate that this patient is moderate calculus, stage 3 perio, the bone loss is furcation. I bet this tooth is mobile just for the way it looks. Like, you can make all these kind of assumptions that are probably pretty close to accurate, but you will never know exactly what's happening if you don't do a full perio charting and periodontal assessment. Does not show tooth mobility. So you can guess, but it's, just because you can see how much, there's a widened periodontal ligament space, or there's a lot of bone loss. It looks like the tooth's barely hanging on by a thread. Sometimes though, there can be a lot of bone and the tooth can be mobile because there's an occlusal, constant wearing and some kind of a constant trauma from biting, and that can cause mobility. Okay. Benefits is that it does show the changes of the bone over time. You can compare one x-ray to another from 3-6 year, whatever period. You can see some tooth and root morphology. So there does give you some help. You can see if there's changes in the PDL, like if the space is getting wider. You can see furcations, especially if you get a good angle and once the furcation is a little bit more involved. If it's a very, very like just barely class 1 furcation, it might not be visible at all, but the more it gets worse, the more obvious it'll be. You can see abscesses, local factors like overhangs, calculus, food trap spots, things like that. And then you can see pathology like abscesses and stuff. Periodontal examination is incomplete without accurate radiographs. So you really need both. So when you guys are doing your SRPs, you should always, always, always have your radiographs and your periodontal charting. Now, unfortunately for us, we kind of have to toggle between the two. So in an office though, if you are able to get both of those up somehow, or at least frequently remind yourself, because that will help your SRP be that much more complete, because you might not feel with your instrument that you can go into a certain area, but then if you look on your radiograph and you see your perio chart, you're like, oh, I better go back here and make sure I got everything. So you use them as your resources while you're cleaning. What type of radiograph is best to view bone loss? Yep, a bite wing. And what is it about a bite wing that makes it accurate to see the bone? What is it about the technique of a bite wing? It's really parallel, right? Like we're coming straight in. So it's a very parallel technique. The film is behind the teeth and the central ray is coming in very perpendicular. So and then this over here, this film shows you how, if you get a really good paralleling technique, look at how the bone looks here, especially like here as compared to this. Like, isn't that like, or like, look at how well you can see the bone level here as opposed to here. These are the same teeth, the same mouth, but, or like, look at this where the bone level is way up here. And then look at how it looks like the bone's here, because you're getting a huge amount of distortion, because this is done with like a bisecting. So in order to get really accurate bone level, you want a very true paralleling technique. So when you're taking your PAs, it may be very difficult in some areas to get a really accurate paralleling technique. You might end up getting distortion. But if you take an FMX and you have your bite wings, and they're vertical bite wings, if you need them for a perio patient, that might be your best opportunity to get the best image of what's actually going on in your mouth. So you can see the bone level a lot better. Vertical bite wings are really important to see the bone. You can see that we've already talked about that. We cut off the bone all the time. And then paralleling is better than bisecting for seeing a good bone level, a true to life bone level. Okay, so we're seeing different things. Periodontal disease. So peri meaning surrounding the tooth. It's a group of diseases. You'll learn more about it. Destruction of all that surrounding supportive structure. So the periodontal ligament, the bone, all of that starts to degrade around the tooth. The cemento-enamel junction, the CEJ, is important because the bone should, in a healthy mouth, the bone should rest just 1.5 millimeters, no more than 2 millimeters below the CEJ. So we look at that as like our line of kind of healthy bone level. And then you want to note the alveolar crest, which is the top of the bone in between the teeth. So we're looking at the crest, and it should be visible. Hopefully you've got the angles nice enough so that you can see the shape of the alveolar crest nicely in your picture. The alveolar crest, like I said, it should only be no more than 1.5 millimeters to 2 millimeters from the DEJ, like below. In the anterior, it's going to look a little bit more thin and pointy. In the posterior, it can look very flat. But you notice what you can see is you can see this whiter outline here, and that's the lamina dura. And sometimes when we are just seeing the beginning of bone loss, that lamina dura, it starts getting like moth-eaten. So the height might be okay, but it starts getting kind of a funky, little bit thinned out look to it. And that's like just the beginnings of maybe some very early mild bone loss. So the lamina dura should follow all the way along. You should be able to see it kind of outline. And then the next layer in would be the PDL, or the periodontal ligament space. And then you see the cementum. Bit of a sandwiched look. Some people, it's just more obvious than others. You'll just depends on the person. Should be continuous and uniform. So when we're evaluating the periodontium, we look at the location and the condition of the alveolar crest. So how kind of smooth and, like continuous does it look, or is it starting to look kind of jagged and like moth-eaten, or is it, really starting to go far below the CEJ? Lamina dura, we want to look at that. We also want to look at the periodontal ligament to see if it's visible and if it's widened. Some people will have a widening if they clench and grind. I tend to have pretty wide periodontal ligament space because I've clenched and grind literally my whole life, and I do it every night. So you just start to see these long-term sort of effects. And everyone's just different, but that's what's good about seeing somebody on a regular basis and comparing X-ray to X-ray is, if something is drastically changed, you can tell if you're kind of comparing films. You can see local factors that could affect the periodontium, like overhanging restorations, places where food is impacted, if they have a space or a diastema, calculus, and occlusal trauma. So here's some examples of relatively healthy periodontium, although this is kind of an interesting one because the CEJ is here and the bone level is here. So it's a fairly this is actually a fair amount of space between their CEJ and their bone, but you can see the lamina dura, it looks pretty good, but I would almost venture to guess if there isn't the ever so slightest bit of bone loss starting there. But in general, this is probably a fairly healthy periodontium. This one, so you can kind of see it looks kind of flat and rounded. This one, sometimes it's just the quality of the film too. But in general, those are fairly good examples of healthy periodontium. And then of course, extreme, obviously diseased periodontium. You can see a lot of bone loss. The lamina dura oftentimes is gone, but it kind of almost looks like there's something here. But in general, usually the lamina dura, especially on the crest, is gone. But this is obviously a ton of bone loss. The CEJ is way up here. The bone level is way down here. You see a big old bifurcation involved. So calculus, we were looking at calculus already. So this is like a ginormous spur of calculus on the sides of the teeth. And then we can see it in rings. So you can actually see it on the facial and lingual surfaces. You see it on the side, but you can actually see it all through here. It's so heavy. It's like a ring of calculus. And you could also see that probably with your eyes as well. And this is an example of teeth that, because there's so much bone loss, you can sort of give a good educated guess they might be mobile. So what would we call this over here? I heard suture. Median palatine suture. So think of palate. If you think of palatal suture, that, that's probably half the battle and probably would give you the point for that. So because it's on the palate, right? And it's a suture. I don't know why I would think, what will help you remember suture? It's suturing both sides of the palate together. I don't know. But median palatine suture. Median means middle. So it's the middle of the palate suture. Huh? Yeah. I don't know. I didn't really hear what you said this second. Oh, was it related to that? Okay. Oh, okay. Yes, I'd be totally out of that because I'm like, I don't know what you're talking about. Okay, so here we have some examples of overhangs, some pretty major overhangs here and here. You can see some yeah, I know, right? Who is this dentist? Calculus. Yeah, he needs to retire. Calculus. You guys are going to be this is what happens if you're not already a dental assistant thinking in terms of good dentists, bad dentists, you will shortly. And then the other thing that's really awful that you have to keep in check is when people come to you from other practices and have seen other hygienists, you start to be like, how is this hard? You know, because you'll see all this calculus, and we can't judge not lest ye be judged. So, but there are times when you're gonna get into a situation where you're gonna have to explain to your patient why they have gobs of calculus and they've been seeing somebody their whole life. And why didn't they get that? That's a great topic for ethics. You'll reach that next year. But anywho, I got off topic. Let's move on. So more calculus here. Calculus is just going to look radiopaque, not as radiopaque, obviously, and it's just going to look bumpy or like a spur. So it's gonna have this kind of extra look. Teeth should be pretty uniform and smooth looking. So if you see any kind of bulgy bumpies or like a little triangle, like a little spur, then you're looking at calculus. And it can get smoothed down and get burnished. So it can look like a smooth bump. If the hygienist did a good job of smoothing it, but didn't remove it, it can look like a smooth bump as well. So here's some more calculus here. We can see it on the distal underneath the restoration here. People get nervous about scaling around crowns because they're like, oh, I'm gonna pop up the crown. But the calculus is usually hanging on to that margin. So that's when you do some nice horizontal strokes to come around the side, but you have to get the calculus that's embedded there in the margin of the crown. Yeah. This one. The calculus is all kind of bumpy. Yeah, see that? And all the way, look, it goes all the way down to here. Look, all this bumpy, lumpy. Bumpy, lumpy calculus. What's this? External oblique ridge. Yes, that's what you meant. I know, it's been a long day. It's not fair for me to ask you these. You guys already had one exam. Okay, calculus, local factors, decay. So what do we see? What can we see here? What's going on here? The big old occlusal caries. What do we have here and here? Overhangs. What do we have up here? Calculus, good. So we got all kinds of fun stuff, probably some incipient decay here. There's all kinds of stuff. It gets a little blurry. Okay, so now we're going to talk about the staging. What time is it? We got like 20 minutes or less. Okay, so staging, it's important because they're going to ask you when you are seeing your perio patients, they're going to say, okay, what's the AAP of this patient? And you have to know. But you're going to get far more in depth next semester. So we want to know this because you are going to be tested on this and have to pick out, but you're going to get a lot more talk about details of this and that. But this is the general overview of what you need to know. When you're looking at somebody's mouth, if there's less than 30% affected by something like bone loss and or what have you, if it's less than 30%, say they have twos and threes, 2, 3, 2, 3, 3, 2, 3, 3, 2, 3, 4, 5, 5, 4, 5, 6, whatever. And it happens in one area, like around 13, 14, and 15. And there's just, and everywhere else, 3, 2, 3, 1, 2, 2, 1, 2, blah, blah, blah. Then that's localized. That's going to sound really funny on my recording. You guys are going to, that'll be a fast forward through that. But then generalized is if it's more than 30%. So you can just count up the teeth in their mouth. So they have, say they have 32 minus 4. So they have 28 teeth in their mouth. Less than 30% of those teeth is considered localized. More than 30% of 28 teeth is generalized. So fairly easy thing to say localized, generalized. Same with plaque buildup and stuff like that. Then there's the pattern of bone loss. So you have horizontal bone loss, meaning that the bone is just going down like this. It's just flat across, horizontal. Vertical is it might be staying up fairly high on the premolar, but it's dropping down on the molar. So the bone loss is vertical. Just on a side note, periodontists like vertical bone loss because they can build into, they have walls to support the growth of new bone, whereas horizontal bone loss that's just dropped, they don't really have a structure to help build it. So periodontists prefer vertical bone loss. Anyways, and so then there's furcation involvement, which is going to be a shadowing or a radiolucency between the roots, the legs of the tooth or the roots. Then you have moderate severe ridge defects. So the actual like structure of the arch of the ridge of the mandible and maxilla. So this is a new thing for the past, you know, it's been around now for 2-3 years, but they're just now changing it on the national board. It's been slow to change. Things used to just be mild, moderate, severe. Now they stage it. So you know how like if somebody gets cancer, it's stage 1 cancer, stage 2 cancer, stage 3. So they've matched it up in dentistry for periodontal disease to match up kind of similar. So stage 1, we have 15% or less. It is, so that's very little. So this is considered like mild, and 15% or less of bone loss. So that's not a lot. Stage 2, 15 to 33, somewhere in that window. Stage 3, it's going to be more than 33, extending into that middle third. And then stage 4 is severe. It's just dropping down below, like halfway below. So we'll look at some pictures to give it some tangible, something for you guys to actually look at. But, oh, severity, complexity. Okay, so horizontal bone loss, you can see what you're measuring, what you have to be aware of is that the bone loss pattern is going to mimic where the CEJ is. So here's a CEJ here and here, and then the bone loss is kind of just dropping straight down. So this CEJ is a little bit higher than this CEJ. But if I were to draw a line from here to here, do you see how this line would be slightly slanted? Do you see how that? So this bone level could be slightly slanted and still be considered horizontal. Does that make sense? Okay, good, because that's a weird thought. But if the CEJ is a little bit from one tooth to the other, if the CEJ is off, the bone loss can also be slightly off and it's still considered horizontal. Now, if you're looking at this or this is a far more, especially this one, this is a far more obvious, you know, the CEJs are here and here, the bone level goes totally opposite direction and very much at an angle. We have some furcation involvement in here, furcation involvement in here, furcation involvement in here, because it's all getting a little radiolucent there. I think that arrow is in the wrong. Oh yeah, so this is showing the CEJ, that arrow, you can ignore this little point. This is showing the CEJ and then the bone level. Okay, so horizontal bone loss. You know what I'm going to do? This is what I'm going to do. I'm going to pause this here because we can't get through all of this. We only have 10 minutes and I think our brains are fried. So what I'm going to do is I'm going to pause this here and I'm going to finish up the lecture, recording it, but this lecture is already recorded on Moodle. So you can, and what it's basically from this point on, it's just showing pictures and the staging and grading. So I have this other little activity here for you guys to bring home. And I'll show this to you too. So you can, last few minutes, we'll pause to pass it around. So this is probably not perfectly to scale, but this is basically, you can color these different colors. So if we have the CEJ up here, which is where the bone level can be just a hair below the CEJ and still be considered healthy bone level. But then if we get somewhere between that level and 15%, we're in a stage 1. But if it goes below 15%, we're in a stage 2. And if it goes below 33% and down, we're into stage 3 and 4. This is furcation involvement here. And then this is vertical bone loss here. And this is horizontal bone loss here. So you guys, I'll pass that out and you guys can just use that also. I kind of did it at the same time as I did this one. So I'm gonna give you guys each half the stack and pass them around the room. And then I'll record the rest of this and post it, but there's already a recorded lecture. So you guys can do that, you know, watch what was on there from last year. Okay. Bye, Jessica. Feel better.
Bye. Thank you.